The next relative consideration is high fever. We know that an elevated temperature is associated with an increase in oxygen toxicity. And it's for that reason that many hyperbaric programs routinely add air brakes anytime the patient has a temperature above 100 degrees. An easy way to remember this concept is to think back on your pediatric experience, at least if you've taken care of children. You know, children can have this phenomenon of a febrile seizure. Well, this is like a febrile seizure, except it's occurring in an adult. And it's an adult under very special conditions. A fever breathing pure oxygen under pressure can result in an oxygen seizure. So if that helps you to remember the association, then by all means use that. But in any event, the addition of air brakes is widely used in practice anytime a patient has a temperature greater than 100 degrees. And by the way, some of the disorders like osteomyelitis, certainly anaerobic infections, we would expect these patients to have a fever. The next relative risk would be individuals who have reconstructive ear surgery. If they have had some kind of procedure in the middle ear, then the best thing is to consult with the ENT surgeon. They are very familiar with middle ear dynamics. They may opt to put in PE tubes, pressure equalization tubes, but the key consult is to talk with them before proceeding. The next relative risk here is congenital spherocytosis. What is that? Well, a normal red cell should be a little flat biconcave disc. People with this disorder have big, puffy, fluffy, round red cells, hence the term spherocytosis. Now, the specific abnormality is a defect in the hexose monophosphate shunt. This particular metabolic pathway is the first line of defense against oxidant stress. So a person with congenital spherocytosis would be very susceptible to a high exposure to oxygen. Now, this doesn't preclude HBO, it's just a risk consideration. Providing supplemental vitamin E may allow them to receive HBO. And you may worry that, well, could I miss this diagnosis? Well, not really. Anybody who's ever had a CBC has already been diagnosed, because the Coulter counter, that is the automatic machine that measures the red cell volumes, will probably be sending off alarms like the pathologist has never seen, because they have such enormous corpuscular volumes. So it's unlikely that the patient would not know this diagnosis. They've probably already been diagnosed, and as I mentioned, it's extremely rare. The next relative risk here is a history of optic neuritis. Now, this is a risk that's, I think, poorly defined, but again, as you read various textbooks, you may find authors that express a concern. And some of these cases of anecdotal blindness have been associated with multiple sclerosis. There was a time when there was a great deal of interest in utilizing HBO to see if it might help what is a very frustrating disease. MS, if you're not familiar with it, is a demyelinating disease of the central nervous system. And by the way, when people have MS, oftentimes the optic nerve is characteristically affected. The disease is associated with exacerbations and then remissions. So it waxes and it wanes, and it's really hard to know whether HBO was causally associated with the deterioration in vision, or could it have been simply disease progression. Nonetheless, you may read of these things, and it's difficult to interpret, and bottom line, to really be sure. So it's by no means a contraindication, but probably in the spirit of informed consent, if a person has this disorder, a risk-benefit assessment between the physician and the patient is a reasonable approach. Another ophthalmologic concern is recent retinal repair. And the concern here is that if the patient has had surgery on the retina, the ophthalmologist may have employed an intraocular gas. Now, one of the more common disorders in terms of retinal surgery is detached retinas. And the way that the ophthalmologist holds the retina in place is to instill some gas that tamponades and pushes the retina down, oftentimes when they pulse it with a laser. The gas that the ophthalmologist uses, though, is a very special gas. It's a gas that is not very soluble in plasma. You know, most of the gases that's used in endoscopic surgery is CO2. And in the physiology session, we looked at that enzyme, carbonic anhydrase, and learned it's a very powerful catalyst to take the gas and move it into the solid state. But the gases that the ophthalmologists use are not CO2. CO2 is far too vasoreactive, and the gases that they use may hang around for up to 30 days. So what's the problem? Do we run the risk of a tension eyeball? Well, certainly not, but the problem is that when we compress the patient, let's say to 2 ATA, that bubble then shrinks down. When we return to the surface, it re-expands right back to the original size. But if we go at this day to day, it shrinks, expands, shrinks, expands. And this poses a mechanical stress for something as delicate as the retina. So we run the risk of subretinal bleeding, further detachments, and so on. So bottom line, if there's been any retinal surgery in the past 30 days, be sure to check with the ophthalmologist to make sure they didn't use intraocular gas. And if they did, this would preclude HBO. Now, here's another common question. What about my patients who have had cataract surgery? Well, cataract surgery is very common, and that's surgery involving the anterior chamber of the eye. And so these patients certainly can receive HBO. They, of course, need to follow the post-operative instructions of the ophthalmologist. If they want them at bed rest for the next couple of days, getting out of bed and coming into HBO would violate that order. So just make sure it's consistent with what the ophthalmologist has recommended. But understand this, there are no physical gas laws at play with cataract surgery. Now, the next relative risk that you may read about is acidosis. I don't believe that acidosis really poses a significant risk. The question is really what kind of acidosis. For example, I see a lot of patients with diabetes. A lot of patients with diabetes also have kidney disease, many of which are on hemodialysis. If you have kidney disease, you of course have a metabolic acidosis almost continuously with bicarbs of 18 or 19. I've seen no untoward effects. In contrast, if you have somebody with a lactic acidosis, that's a very different kind of acidosis. So I find this to be, again, a fairly general, unqualified, nonspecific statement, and I want you to be able to interpret this in the context of what we know and don't know. Now, the next relative concern is patients who have concurrent radiation and are also receiving HBO. In our historical overview, we noted that there might be some theoretical benefits to this kind of strategy, but there is no evidence at the current time. In fact, there may be a bit of a concern. And this is based on a study by Dr. Feldmeyer where they were looking at concurrent HBO with radiation given to the spinal cord. The thought was HBO might protect the spinal cord. So what did they find? Well, they found that the animals that got HBO while they got radiation actually had a worse outcome. And with that in mind, I really think it's safest not to provide HBO simultaneously with radiation. Why? Well, in the adult, most cancers are between here and here. So what do we have? Well, we have the spinal cord. And it's a good chance the spinal cord may be within the portal of radiation. One could certainly talk to the radiation oncologist. They tried to design the therapy to avoid the spinal cord. But that being said, it's probably far simpler just to suspend HBO or not provide it until the radiation is finished. So how often is this a problem? Well, in 25 years of practice, I've only had this happen once, so it doesn't happen too often. Now, what you will see is a whole lot of patients who have had radiation and are presenting 6 months or years later. We call that late effects of radiation, and we'll talk more about that in a session on radiation injury. Steroids. You will read in textbooks a concern expressed about steroids, but I guess the real question is how much steroid, and there's really no way to know how much is too much. Now, the use of steroids in modern medical practice have become more and more commonplace. For example, asthma. In the past, it was largely managed with theophylline. Today, it's primarily managed with steroids. My own particular experience is that patients receiving 20 to 40 milligrams of prednisone, which is a typical dose for asthma or perhaps for people with rheumatoid arthritis, sometimes osteoarthritis with flares, that there really is not any significant or perceptible increase in oxygen toxicity. With patients that are receiving extremely high doses, perhaps 100 milligrams of prednisone or Decadron or high-potency steroids, there might be a concern. But the take-home message, I think, is that in the typical dose that most of us run across in day-to-day practice, this should not really pose a significant concern. The next area is narcotics. Certainly for patients who have chronic wounds, there oftentimes are pain management issues, and there's nothing inherent in narcotics that would increase the risk. Now, I think many of you know that Demerol, if given in high doses, can be metabolized to oxymapyridine, and that particular metabolite is seizurogenic, so to speak. But nobody in an outpatient setting is going to be getting high doses, and most people, even in the inpatient, try to avoid giving that much Demerol. Certainly, if your patient is overly medicated and snoring and sedated, what can happen? CO2. Carbon dioxide may rise a little bit, and now we have a scenario similar to what we discussed earlier in your patients with lung disease. But the bottom line is narcotics, in and of themselves, really don't present a significant problem other than the risk of overmedication. The next relative consideration is patients on insulin. It's a known effect that insulin may decrease their daily requirements of insulin. Let's say you have a patient that's receiving 30 units of insulin a day and they notice a week or two later that their insulin requirements have dropped. Well, this is related to HBO. The exact mechanisms are not really understood, but it's thought to be due to a change in some of the enzymes that metabolize insulin. For example, succinyl dehydrogenase and other sort of enzymes. Nonetheless, the clinical utility is recognizing that their insulin requirements may decrease. Once HBO has been discontinued, it will return back to normal. Almost all patients on insulin are on sliding scales, so they're going to adjust their insulin up and down depending upon the daily requirements. But they may turn to you and ask you, is this something I need to be concerned with? Do you know what's going on? And simply reassure them that, yes, we do see this. It's a short-lived phenomena associated with HBO, and your requirements will return back to their previous baseline. The next consideration is nicotine. One thing's for sure, we don't want to have patients smoking in the hyperbaric chamber. For the simple thing, it isn't going to last, but obviously you recognize the risk for fire with these individuals. But the concern with smoking is that it can have a vasoconstrictive effect. This reduces the microcirculatory flow. It can be detrimental for a whole variety of problems. Now, on this particular topic, many hyperbaricists have strong feelings and feel that if the patient cannot stop smoking, then they're not going to give hyperbaric oxygen altogether. It's kind of like the cardiac surgeon who says, you know what, I could do a coronary bypass graft. It is a high-risk procedure. It can be associated with complications and so on. But if you were to stop smoking, that alone might be as beneficial as this high-risk surgery. So if you're not going to stop smoking, then there's no point in me operating. Myself, I'm kind of a moderate. I beg, I plead, I ask that they at least, stop for the time while they're getting HBO, which might be 4 to 6 weeks, and then if they want to resume, then that's certainly their decision. They know what my opinion is, of course, stop smoking altogether. But nonetheless, you'd be well served to learn about various smoking cessation programs because that alone can be very helpful just in getting these difficult wounds to heal. And certainly if the patient is going to continue to smoke, they should try and avoid any cigarettes, at least for the first 4 to 6 hours prior to HBO treatment. Again, you'll have to arrive at your own philosophical decision on this particular matter. And keep in mind it's not just smoking, it's nicotine. So substitution of Nicorette or nicotine patches, this is not a solution. Nicotine is nicotine regardless of the form in which it is delivered. The next relative risk consideration is ointments and creams. We'll have a expanded discussion of this really under fire safety. The biggest concern is that ointments and creams contain hydrocarbon bases, some of which are volatile, and in a pure oxygen environment they may pose a risk for fire. So we'll talk more about that later, but it's certainly relevant to the particular topic at hand, which is risk considerations. Now that pretty much concludes our discussion of risks, and what I'd like to turn to next is side effects of hyperbaric oxygen. There are a number of side effects that you should be aware of for your patients receiving HBO therapy. For example, if your patient has cataracts, there can be an idiosyncratic growth of these existing cataracts. Now, HBO is not cataractogenic. That is to say, if the patient does not have a cataract, HBO does not create cataracts. But what it may do is encourage the growth of cataracts. Now, again, this is idiosyncratic. That is to say, the patient may or may not experience this as a problem. So it's important from an informed consent perspective that if they have cataracts, you should advise them of this phenomena. The next side effect is nearsightedness. We know that patients that are receiving hyperbaric therapy may actually have an improvement in their near vision and a deterioration in their far vision. This is commonly noted after about 20 to 30 treatments. And what the patient will typically say is they're having problems seeing street signs as they're driving in for their treatments. Now, if the patient is having difficulty with reading, then this is a near vision problem and should probably be referred to an ophthalmologist for further evaluation. Now, this change in vision is a transient phenomena, and vision typically returns to baseline in about 2 months. So why do I have 3 months? Well, if you tell a patient 2 months and they don't return, then of course your pager is going off and they're concerned. So I found it's just far more practical to say 3 months, and then everybody goes home a winner. The next side effect is paresthesias. Patients may experience a tingling feeling in their fingers. Now, if you have a 300-pound patient complaining of this, do you work them up for carpal tunnel? Absolutely not. You recognize that this sort of problem is related to HBO. Now, no specific treatment is really required. Simply reassurance typically disappears within about a month of stopping treatment. And what do I tell them? Well, in this case, again, I tell them 2 months. The point is everybody's going to get better, and you really don't need to evaluate this. Simply understand that it's a side effect of the treatment. The next consideration, informed consent. Certainly, we must always obtain informed consent for all of our patients. You, of course, need to develop the proper paperwork and documents for your program. But here are the elements that I personally cover with each of my patients. At a minimum, I inform them of the risk of fire, barotrauma, cataracts, visual changes, and oxygen seizures. And I typically add that final statement at the bottom there. These risks include but are not limited to suggest that I may have talked to the patient about a whole lot of things, but I certainly talked to them about these specific things. Now, in obtaining informed consent, it's not just what you say, it's how you say it. For example, I could tell the patient that we're going to give them an oxygen-based treatment, so there's some things that we need to talk about. For example, oxygen's associated with the risk of fire. You remember that whole Apollo disaster, and then there's a chance of barotrauma. We could collapse your ears and rupture your lungs, have cataracts, and seizures. So how about it? Do you want this? Well, of course not. So I typically start the whole consent process by reminding them that nobody is allergic to oxygen. And then on the matter of fire, I point out the fact that there has never been a major clinical fire in the United States. Although, as you'll learn in the safety session, that certainly these chambers are exploding all over the world every few years. But it is correct, there's never been a clinical fire. Now, there have been fires in the United States, but these have involved naval chambers and other sorts of chambers. The next comment certainly is barotrauma. I certainly don't use a $10 word like barotrauma, but I explain to them the effects of pressure. And I remind them that really they should never have any injury to their ear, because if they start to feel pain, we'll go ahead and stop that change in pressure. Now, with the cataracts, of course, if they have existing cataracts, there's a slight chance, an unpredictable chance, that they could get worse. And you know, cataracts can be operated on, but if we're talking about a limb salvage scenario, a chronic wound that could result in amputation, and we lose that leg, there's nothing we can do to restore that. So that's an important, I guess, risk or relative risk to keep in mind. Visual changes, as I mentioned, is a transient inconvenience. And then oxygen toxicity. I usually tell the patient, I know this sounds strange, but you know, your brain can get so much oxygen, it doesn't know what to do with it. It gets overexcited, you have a fit, a spell. You know, the words you use sometimes can convey various things. I certainly wouldn't say that you have an epileptic fit or a convulsion. These seem to be much more violent events as opposed to simply saying something like a seizure or a fit or a spell. And you know, finally, I oftentimes will sort of set the whole picture in perspective. At my hospital, there happened to be a sandwich shop across the street, and everybody driving in could see that sandwich shop. And so I'd often point out to the patient, you know, the good news about oxygen, nobody's allergic to it. But there's always risk in everything we do. For example, that sandwich shop across the street, the mere fact that I step out of this building puts me at risk. I could get hit by a car crossing the street. I could get mugged. And if I'm lucky enough to get to the sandwich shop, I could get food poisoning. So there's always risk. Now, when you talk about the risk of oxygen seizures, and we'll look at that later, the recorded risk ranges anywhere from 1 in 3,000 to perhaps as few as 1 in 10,000. So I typically round it off and I say about 1 in 5,000. And of course, there's no permanent side effects as far as we know from an oxygen seizure. But these are the things that I cover. Again, it's not what you say, it's how you say it. I think you put it in perspective, easy terms that the patient can understand. Now, there are just a couple other topics here to look at this particular time. Since we're talking about risks and concerns, it's useful that we look at the pregnant patient. There was concern that hyperbaric therapy might be associated with some adverse effects. After all, every woman worries about their unborn child. But these early concerns have largely been dispelled through some animal studies and a vast Russian experience utilizing HBO for a lot of obstetrical problems. Uteroplacental insufficiency, for example. And there really have been no adverse effects reported in the literature. Now, we're going to look at that more closely in the carbon monoxide session, because it would only be the acute indications where we would really need to provide HBO. For somebody, if they do have a problem wound, we typically would allow them to complete their pregnancy before providing HBO. Now, the other common concern while we're on this topic would be cancers. Again, there's early concerns that if HBO helps cells do more, be more, could it not grow my tumor? Could it lead to recurrent cancer? And the answer is no and no. And again, we'll look at this in greater detail under the more appropriate heading of radiation injury, because radiation is used in the management of cancer, and all patients being treated for radiation injury will have had a history of cancer. So we'll look at that with greater detail under that subject matter. So at this point, let me summarize all the things we have talked about in this session. We've talked about the absolute risks, and they include untreated pneumothorax and a history of spontaneous pneumothorax. Now, with a spontaneous pneumothorax, it might be considered an absolute contraindication in a monoplace chamber. On the other hand, with a multiplace chamber where you can reach the patient, that would not necessarily be the case. We also talked about several medications: adriamycin, bleomycin, and cisplatin. These are all used in the management of cancer. And we also came to realize that there is now changing opinion on the matter of bleomycin. In the past, it was felt to be an absolute contraindication. New data suggests that that may not necessarily be the case. We certainly recognize that anybody with bleomycin must be monitored very carefully for the possibility of bleomycin-induced pneumonitis. It's rare, it is idiosyncratic. We've come to recognize that perhaps lung volumes are the more sensitive indicator. In the past, it was thought to be CO diffusion. And then the final medication on this list was disulfiram. Now, on first pass, this probably seemed like a very long list of risks to consider, but reflect for a moment on all the medications you use every day in practice, any one of which, if you look up in the PDR, has a list far longer than what we have here. And also, think about what I didn't talk about. There's no drug-drug interaction. That is to say, if your patient's on hyperbaric oxygen, we don't need to adjust their Coumadin or check their INRs or look at those kind of effects. And as I pointed out, there certainly is no allergic reactions to oxygen. So in contrast to most of the drugs you use in practice, this is a fairly short list. You should have in your forms built-in questions for all of your patients coming to treatment, asking them, do you have any lung problems? Have you ever been treated for cancer? And if so, what are the medications? And do you have any history of alcoholism? That's useful to know if patients have a risk for DTs, delirium tremens, or alcohol withdrawal. And finally, have they been treated with that drug, disulfiram or antabuse? Beyond that, we're simply a longer list of relative risks, none of which really preclude HBO. We talked about seizure disorders. Certainly we can treat patients who have a history of seizure disorders, but certainly if they are occurring on a weekly basis, common sense would suggest that's not a candidate. We talked about people with chronic lung disease and CO2 retention, and your asthmatic patients, how we would approach those. With the asthmatics who have severe asthma, and I've arbitrarily defined that to you as a patient who wouldn't leave home without their inhaler, probably should have 2 puffs before each treatment, because that wheezing is just the tip of the iceberg. And certainly I want to stress that with an active asthma attack, we certainly would not proceed with HBO because of possible air trapping and the risk of whose law? Boyle's law. That's right. We also talked about high fever. Anybody with a temperature over 100 is at risk for possible oxygen seizures, and we'd want to provide those patients with an air brake. We looked at the history of thoracic surgery and came to appreciate that this is sort of a general unqualified statement. Certainly these people should have a baseline chest x-ray. We talked about congestive heart failure. Certainly with an elderly population, this is an area that you'll spend a lot of time reflecting on. And although HBO can precipitate heart failure, if you make sure that your patient lets you know at the earliest moment they're having trouble breathing, then you can take immediate steps. Put them on air. The moment they go on air, they begin to lose the oxygen-induced vasoconstriction that has led to the increased afterload, to use the term of the cardiologist. So very important with these patients, communicate, communicate. Every day they come to HBO, remind them, if you feel short of breath, what do you do? Let me know, because I can begin the treatment with air, we can decompress, we can modify protocols, and I've talked about that. Finally, cataract exacerbation. It's important your patient is aware of that, and if they have any change in vision, certainly an ophthalmologist can provide further insight and recommendations for case management. Then finally, there was a list of other incidentals that we talked about. For example, recent retinal repairs, history of ear surgery, chest x-ray lesions, spherocytosis, and optic neuritis. Again, this total list is far shorter than any list you would find in the PDR. We looked at some of the side effects associated with HBO. For example, visual changes, a deterioration in far vision, sensory tingling. And then there are a few other side effects we haven't really spoken of in this session, but for completeness, that would include oxygen toxicity, CNS, and pulmonary. To learn more about those topics, I would direct you to the session on oxygen toxicity. Well, that pretty much wraps up this session on risks and side effects. It is perhaps one of the longer sessions of the curriculum, but certainly one of the most important, is assessing risk for each of your patients to determine the relative benefits of HBO, and for those with specific risk factors, taking the appropriate steps. For our heart patients, communicating. For our patients with lung disease, possible pre-treatments. Doing that oxygen challenge. Checking to see if they have CO2 retention. So I appreciate your taking time to review this particular session. I hope your experience here is going well. I'm Dr. Bob Bartlett on behalf of the entire production staff here. Thank you.